ABG interpretation, case study, Aglan protocol. How to study ABG? 4 items. Number 1, listen carefully to the clinical history. Number 2, study the lab investigations, including the ABG chart. Number 3, look at this Aglan ABG table to fill in the spaces measured and calculated. Number 4, back to this Aglan ABG table to study pH, chloride items, bicarbonate items, oxygenation state of the lung, and ventilation state of the lung. Clinical history. Study of the clinical history will be important for 2 things. Number 1, to anticipate the pathophysiology. Number 2, to anticipate the sequelae of events. Anticipation of the pathophysiology, like what? If the patient is vomiting, is going to lose chloride, gain bicarbonate, to develop hypokalemic metabolic alkalosis. If the patient develops diarrhea, will lose bicarbonate, gain chloride, to develop hyperkalemic metabolic acidosis. If the patient develops diabetic ketoacidosis, bicarbonate will be consumed, so he will develop high anion gap metabolic acidosis. In a renal failure patient, bicarbonate will be consumed by the fixed acids to develop also high anion gap metabolic acidosis. Methyl intoxication will be associated with the formation of formic acid to consume bicarbonate to develop high anion gap metabolic acidosis. Stable congestive heart failure, the patient will have hyponatremia, maybe on diuretics like furosemide to develop hypokalemic metabolic alkalosis. Liver cirrhosis patient will have hyponatremia, hypoalbuminemia, hypokalemia, and develop metabolic alkalosis. Anticipation of the sequelae of events, like what? If the patient develops vomiting, then became shocked, vomiting will develop hypokalemic metabolic alkalosis, then shock will develop high anion gap metabolic acidosis. Lab investigations, you should study sodium, chloride, potassium, BUN, serum creatinine, random blood sugar, ketone bodies, and serum lactate. Then come to the ABG chart to study it, to see the values. For the calculations of the calculated items, don't forget these formulas, these equations. I collected it in the form of golden rule in these 4 slides. You should know it by heart. Number 3, look at the Aglan table and fill the spaces. These spaces are 2. Number 1, the measured items will be taken from the lab investigation and the ABG chart. Then the calculated items with these red arrows, you have to calculate it before starting the Aglan ABG table. Number 4, study Aglan table. This Aglan table, as I have mentioned before, is formed of measured values and calculated values. To start with, number 1, by the pH. Number 2, the chloride items. Chloride items, serum chloride, chloride sodium ratio, corrected bicarbonate, and strong ion difference. Number 3, bicarbonate items, serum bicarbonate, anion gap, buffer base, strong ion gap, base excess. Number 4, oxygenation state of the lung, FiO2, BO2, B arterial oxygen, pressure of oxygen of arterial oxygen, and alveolar arterial gradient. Number 5, ventilation state, the pressure of carbon dioxide and its relation to the pH and bicarbonate. To study the pH, for sure, see whether is it normal, acidemia, or alkalemia. Start studying the chloride atoms. Number 2, as I've mentioned before, serum chloride, chloride sodium ratio, anion gap, strong ion differences, and corrected bicarbonate. From these items and from these data, you will come to the diagnosis of the start diagnosis, start pathology, the first pathology. Number 3, studying bicarbonate items, serum bicarbonate, buffer base, base excess, strong ion gap, and anion gap. This will give you the last or the second pathology and the second diagnosis. Number 4, the oxygenation state of the lung will be studied through studying FiO2 and BaO2, and you will come to the formula alveolar arterial gradient to diagnose the oxygenation state. Is it normal or hypoxic? Number 5, studying the ventilation state through studying the pressure of carbon dioxide correlated with bicarbonate and pH. See whether the patient is hypoventilated, hyperventilated, normoventilated, compensated, or not. Case number 8. 15-year-old boy with a history of glucocorticoid-dependent nephrotic syndrome since 5 years of age arrives in a community emergency department because of chest pain, nausea that has progressed to abdominal pain over the preceding 16 hours. The nephrotic syndrome was in remission while the patient was receiving glucocorticoid and cyclosporine. The patient and his mother stated that he had become very thirsty and had been drinking a huge amount of water over the past week. On the day of admission, he had several episodes of vomiting. There was no fever, cough, rhinorrhea, or diarrhea, and no family member, friends, or associate has been ill. The lab investigation is pH 7.19, pressure of carbon dioxide 18, pressure of oxygen 40, bicarbonate 7, sodium 125, potassium 6.2, chloride 81, anion gap 36, blood urea nitrogen 54, serum creatinine 1.5, random blood sugar is 849. From this history, 2 points should be considered. Number 1, this patient was on steroid for a long period, more than 5 years, and this steroid most probably developed 2 pathology. Number 1, steroid stimulates carbonic anhydrase, the retention of bicarbonate, loss of chloride. This means that this patient will develop or expected to develop hypokalemic metabolic alkalosis. Then at the same time, this steroid developed diabetes for the patient, and most probably he developed the diabetic ketoacidosis from this high random blood sugar. So this is very important when we discuss this case. When we come to Aglan table, first look at this. The pH. pH is acidemia, very low bicarbonate, and when you calculate the compensation of the carbon dioxide, it is compensated. So this is metabolic acidosis with compensatory respiratory alkalosis, and this is the pH. The second item to study is chloride. Look at chloride, it's low, 81. Chloride to sodium, instead of being 74, it is 65%. So it is hypokalemic. Look at strong ion differences. metabolic alkalosis more than 40, and look at the corrected bicarbonate 32. From these data, it's clear that this patient was having hypokalemic metabolic alkalosis. And then what happened? Before we go, this hypokalemic metabolic alkalosis is normal and N-gap if you calculate it. Hypokalemic metabolic alkalosis, this is buffer base is high with base excess. This is a data, stable data, before he develops DTA. What happened? This high bicarbonate dropped from 32 to 7. So this is the severe metabolic acidosis. Look at the anion gap, high anion gap metabolic acidosis, bicarbonate low, buffer bases low, less than 40, and severe base deficit minus 26. So this high anion gap metabolic acidosis, why? Due to addition of fixed acid, which strong ion gap is 21. So first, this patient had hypokalemic metabolic alkalosis, then developed high anion gap metabolic acidosis, most probably due to DKA. What about the oxygenation state? He was on room air. They calculated alveolar pressure of oxygen 125. They measured arterial oxygen 40. Alveolar arterial gradient is high, 85. So this patient, most probably this patient had some sort of pneumonia or so, although the history said that there is no fever, or yes, but this is expected with shock or expected with hyperperfusion, but this is the clue for the problem of oxygenation, and should look at for it by X-ray. By the way, the partial ventilatory is normal, and this is a compensation as we had mentioned before. So this patient had hypokalemic metabolic alkalosis, then developed high anion metabolic acidosis with hypoxemia. This patient received treatment. The main treatment was saline. And these are the data. When you look at the sugar drop from 849 to nearly 600. Back again to Aglan table, and you see, number 1, this is the previous state. What happened after you added normal saline? First, you have to study the pH. Bicarbonate increased, still the pH of acidemia, but there is improvement in the pH from 7.19 to 7.25 due increase in the bicarbonate with concomitant compensatory hyperventilation. When you come to the chloride increased from 81 to 101, and the ratio chloride to sodium increased from 65% to 74%. So this is some sort of hyperkalemia compared to this. What happened to this hyperkalemia? Hyperkalemia, this is strong ion differences, decreased from 44 alkalosis to 35 acidosis. So this is hyperkalemic metabolic acidosis. What about the bicarbonate? Bicarbonate improved from 7 to 10. That's why the buffer base increased from 23 to 26. And strong ion gap, which is the fixed acid, improved to decrease from 21 to 90. And at the same time, the base deficit from minus 26 to minus 18. So after infusion of normal saline, the patient developed hyperkalemic metabolic acidosis, but with improvement in the high anion gap metabolic acidosis. Thank you.